Welcome back to Think Like a Nurse 2. Right now our focus is going to be on dialysis. And dialysis actually is a process that takes place where these procedures actually function like that of your kidneys. So when the kidneys are kaput, or the kidneys no longer are functioning like they should for whatever reason, then we start having to look at other means of filtering out the blood. So the way I want you to think about this is if your kidneys don't work, then you will die without dialysis. So there are a couple of different types of dialysis. The first one we're going to talk about today is called hemodialysis. So we know that heme means blood. So hemodialysis is going to be a filtration through the blood, and the second is going to be peritoneal, and we know that our peritoneum is actually our abdominal area, our intra-abdominal cavity, and we're going to talk in detail about these two different types of dialysis. There are both some risks and benefits from each type, but remember that we said if your kidneys don't work, then you will die without dialysis because your body actually will start building up with toxins that will cause will act like poisons, and they'll poison your organs. It'll start to poison the brain, and this is certainly not a good thing. So what we want to do is intervene when our clients start becoming or showing that they're having severe problems, or that they're in an end-stage renal disease process where their kidneys, there's nothing that can be done to help these clients actually recover from the damage that has already been done to the kidneys. This happens a lot with clients that are diabetic or long-term uncontrolled diabetes. This could happen as a congenital defect with your client, or also could happen as a result of trauma, or even from poisoning or drug overdose. So lots of different things can actually cause a client to have to go to dialysis. But remember the lab work that we looked at on our last video, and what was important to indicate whether or not that client was going downhill as far as the need for dialysis, and that was that glomerular filtration rate, or that GFR, and that provided those stages. The numbers provided the stages that let us know whether or not our client was actually nearing an end-stage renal process. So when they're actually ready to have dialysis, the healthcare provider can offer them a couple of different options. So what these different options are going to do is that they're going to come in and they're going to be like a fake kidney for the body, or they're going to have a device that actually functions like the kidney would in removing those toxins and poisons from the bloodstream. The first of those, as we said, was hemodialysis, and we said heme, of course, involves blood. So what we have to think about this for our client is that the client will have what's called a fistula or a shunt that is actually an AV graft, arteriovenous graft, that is placed in the client's arm. And if we think about the structure of the arm and the hand, okay, I'm just going to draw us a little hand here. Okay, we've got it here. Okay, we go up the arm to the elbow. Usually, most of these are going to be located around the antecubital space here, and it's going to be a large, ropey, thick, tight vein where the artery and the vein are connected. And this one really has a lot of danger involved, as your client is at very high risk for bleeding out or for hemorrhage. When they go to dialysis, and a special dialysis nurse will be taking care of them in the actual dialysis facility, but it's up to us to be able to perform assessments of our client. So baseline is very important. What we need to know is whether or not that actual AV graft or AV shunt is actually patent. So what we're going to do is we're going to auscultate, use our stethoscope and listen over the AV shunt and determine if we hear a bruit. The bruit indicates that the actual AV shunt is patent. So we're going to have the bruit, and we're going to auscultate for the bruit, and we're going to feel for the thrill. Okay, so it's going to feel kind of like a little cat purring sensation, or a rush of blood, because that's a really high, fast-paced blood flow, like you imagine a car going really, really fast, zoom. That's kind of how you're going to imagine that feeling or that sensation that's going to be and that arteriovenous graft. So when we're looking at the actual graft itself and determining the function, we have to feel for the thrill and listen for the bruit, and that helps us determine what's going on and whether or not it is actually patent. We also need to make sure that the client still has full range of motion of the hand and checking the coolness or warmness of the extremity itself to make sure that that patency is maintained. Once the client has this particular device, the AV shunt, then this arm can no longer be used for blood pressures or needle sticks. It is strictly to be used for dialysis. Once your client actually goes down to dialysis, they're going to place the heparinized solution, anticoagulant solution, into this shunt, and then the blood is going to go out through a machine and be dialyzed and then be returned to the client. So some things that we need to think about before we actually send them for hemodialysis is, number one, that giving them medications prior to sending them down for dialysis is going to be a futile effort, which means that, when they go for the filtration process, it's also going to filter out those medications that you give the client. So, in essence, if you gave the client their morning medications before they went, then those medications would just be wasted because they're going to be filtered out, and then during the process of dialysis. Your client also may experience or may have a blood transfusion done along with your dialysis or at the same time if your client is said to be low, their hemoglobin counts are low, or there may be a necessity that your client has to have a blood transfusion. So when your client comes back to the floor, when you're taking care of your client post-dialysis, what we need to look at is determine whether or not they have a pressure dressing in place over this shunt or graft, because we're looking for it to be spurting blood, so it could spurt blood everywhere. Remember, we said that's an artery, so that can bleed out very, very quickly. If our client does not have a pressure dressing intact, then we need to intervene immediately and hold pressure and try to keep that particular area from bleeding out. You may also, worst case scenario, if you can't get it bleeding stopped by direct pressure, then you're going to have to apply a tourniquet, but certainly that will be as a last resort. So what's your main function after they come back from dialysis is to make sure that that area is not bleeding. You're going to assess that dressing, assess the site to determine if there is a presence of blood. If your bandage is soaked, then obviously it's bleeding out, so you need to apply some direct pressure to get the bleeding stopped, because the client can be at very, very high risk for hemorrhage and lose a lot of blood volume very quickly if this graft or shunt is not clotted off appropriately. Okay, so we're looking for hemostasis. We're determining whether or not a thrill or a bruit is present, and we're going to check the coolness or warmness of the extremity, make sure that the client has full range of motion, and remember that we no longer can do any venipunctures or needle sticks or blood pressures or any other type of access, IV starts, or anything in this arm. So it takes that arm off the market, so to speak, as far as one of your optional choices for IV starts, blood pressures, or other needle sticks. Okay. Next, what we're looking at is peritoneal dialysis, and it's exactly what it says it is. It goes into the peritoneum, or the abdomen of your client. Like, we've got your client, and we've got the gut, and this is the navel, and we've got an open port here with tube coming out, and then we've got our IV pole, and we've got our bag of fluids. Well, the abdomen, this is called the peritoneum, and this is where the fluids are actually going to be exchanged. We're going to insert a solution, or usually a sugary solution called a dialysate, into the abdomen. It's usually done 4 to 5 times a day, maybe more, maybe a little less with your client, so it can be very inconvenient if your client has this at home. Whereas with the hemodialysis, clients usually go either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday for dialysis. With peritoneal dialysis, they're going to have to go and have to be available at home with the assistance of home health nurse or by themselves to be able to do this very, very frequently. So what we're looking at is the exchange of the dialysate solution. It flows in, like I said, it's a sugary-like solution. It goes into the intraperitoneal cavity, and then say if we put in 1,000 milliliters of your dialysate solution. We're going to leave it, we're going to let it seal and kind of distill in the abdomen, and it's going to attract and pull in all the extra fluid from the body. So we're pulling in the fluid, it's attracting that fluid, it's pulling it into the abdomen, and then it is going to be excreted, which our volume usually is about 1 to 2, or should be, and that means that we're actually pulling off that additional fluid that we need to, or those extra toxins. So we're going at a 1 to 2 ratio. We put in 1,000, we should get out around 2,000 milliliters of solution, and that lets us know that our dialysis is actually working. So what we need to do, especially our clients that are on any kind of dialysis, is make sure that we're carefully monitoring their intake and output, and also their daily weights. The peritoneal dialysis causes the client to be at much higher risk of infection, because what they need to do, number one, it's inconvenient. Number two, they're going to be at home and they're going to be monitoring the fluid that's going in the dialysate. They're going to be monitoring the fluid that's coming out. They're at much higher risk of infection. Usually these are done in the home setting, and if proper sterile technique is not utilized, or hygiene is not as good as it would be in a hospital or closed type setting, then what we're looking at is the risk to the client. And what we're wanting the client to do is monitor what type of solution comes out. Does it have a foul odor? Does it have a cloudy appearance? Is the client running fever? So those are some different things that the client's going to have to be aware of, so that way they can report those to the healthcare provider, because that can indicate that they have an infection or peritonitis, an infection in that abdominal cavity, and that means that they would need acute, immediate medical attention. So we have to look at the two different types of dialysis that are available to our client, and to let our client determine which one of those is going to be most convenient for them and fit best into their lifestyle and their way of life. I hope that you've learned a lot from our lecture today on dialysis, and I hope that you'll join me again on Think Like a Nurse Too.